Good evening, everyone. My name is Kalisvar Marimuthu. I'm a senior consultant. Thanks for the introduction, by the way. So, I will be talking on infection control during the SARS CoV-2 pandemic. There's a lot to say, but there's very little time. So, we will try to restrict to a few key themes in infection control during the SARS CoV-2. So infection control is a field that has been around for eons, right? Everyone knows, and it has evolved and evolved in many different ways for various reasons. In Singapore, the infection control evolved because it was pushed forward by various pandemics that we have seen here. So the science of infection control in Singapore and globally evolved more from the fact that from the need of infection control rather than what the research, need and logic rather than the research and data. This is most of the time, but there are a lot of infection control aspects that actually were ground up from data and solid research. So with that, what I will be doing is I'll be going through how infection control actually, performed very well during this pandemic and how it could have done better in some of the areas. The first part is the good old IPC. It stood the test of SARS-CoV-2 in various aspects. The first part is the training and education, especially just-in-time training. When we talk about infection control, training and education in terms of WHO IPC pillar, training and education is one of the key. And it is important we have been doing it a lot. And this is one of the things that our ICN spent lots of time doing. So PPE training and N95 mask fitting, we had to do lots of it during this pandemic. And it was critical in outbreak response in Singapore, in the hospitals, in the community, and globally. So here, IPC gets full marks, and they did very well. Clean and dirty segregation is also an important aspect of infection control. For the longest time, right, I must say I never really understood what this means. And during the SARS-CoV-2 pandemic, it really dawned on me what it actually means. How do we actually separate clean and dirty segregation? And because we use it to repurpose existing facilities, set up new facilities, and so this clean and dirty segregation is extremely important. Next is environmental hygiene. IPC is big on environmental hygiene forever, ever and ever. Similar to hand hygiene, which is listed there, not in specific order. Hand hygiene, since Semmelweis' time, hand hygiene has picked up really well and pushed forward by lots of gurus of IPC. And environmental hygiene is sort of like a stepsister to hand hygiene, but it's picking up steam, and it picked up steam even before the COVID pandemic. So we were good on all of these, and we did pretty well, I must say. Tracing and testing of hospital contacts and exposure management also is something we have been doing a lot before the pandemic, and we did it quite excellently during the pandemic. In fact, it was one of the key approaches that we took to actually control COVID in the hospitals and also in the community with a slightly different approach. So implementation of IPC principles, including audits and feedback, was also very important during COVID pandemic. If you haven't been doing implementation science in infection control before the pandemic, it would have been very difficult to do it during the pandemic. And this is probably something most people wouldn't do because there just isn't time to do it. But if you have been doing it, it's difficult, but it's difficult, but it's doable to include audit and feedback in the pandemic response as well. Vaccination is big in hospitals because we vaccinate healthcare workers together with our occupational health colleagues or even infection control together. And when the COVID-19 vaccine came about, rolling out vaccination became, I would think, a lot easier in Singapore hospital compared to many other hospitals where other routine vaccination like MMR, Tdap, and influenza wasn't routine. So these are the things that IPC, I think, did excellently. And COVID response, some of the examples of what I said just now was for COVID response within healthcare setting, right? Patients and visitor surveillance took a big role. All pneumonia patients were isolated and tested for COVID-19 before being managed in general wards. And this is something we did for other pathogens before COVID, like TB, measles. If you have rash, if you fever, people consider isolating them. but of course, resource is a limitation during that time. We also screened patients with acute respiratory illness, isolated, tested for COVID-19. Visitors, universal mask up policy for visitors started in February 2020, and this was after lots of back and forth, it started in the hospitals. Now, temperature and symptom checks, we all know temperature checks. We did it because we have been doing it. Fever monitoring is something we do in the hospitals for infection control, and that was continued during SARS CoV2. But community temperature checking may not have a big role to play in this pandemic. The next one, we are not sure yet. So this is NCID's National Center for Infectious Diseases entrance, and you can see we created a pathway to actually navigate, to make sure people follow certain route to actually after symptom screening, temperature checking, then can they go to the ward offices, etc. Why we could set this up quite fast and identify ways to implement it quite easily, because it's something we have been doing in previous outbreaks and previous pandemics. COVID response within healthcare setting was the main pillar was the staff surveillance. A universal mask up policy since started, we actually have audits in place. We actually audited staff and gave feedback to their reporting officers on their compliance. Staff with acute respiratory illness symptoms are screened and are screened at parent institutions. Temperature monitorings were done twice a day as well. And this is one of the systems that are used in Singapore hospitals, the S3 system, where all staff's personal protective equipment like mask size and their vaccination status, travel histories, everything is input here, and it can be visualized quite easily. Thanks to Dr. Angela Chow from Tan Tock Seng Ocean for giving me this data. And of course, EPI unit played a great role during this pandemic, and we all work together, EPI unit, occupational health and infection control. So this is how, and the fact is we have had this before the pandemic, and we just used it for the pandemic. So this is where I think IPC, occupational health, EPI unit and all did very well. And this is the other things that was unique in NCID. Now other hospitals are using it. Is the RTLS tracker, which I carry. We all are expected to carry, charge it, and then you get this beep 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 email messages, etc. To if you don't charge it. So with this, the contact tracing became much easier when we were doing it aggressively. And we all know in the community there is a Trace Together where we use it for contact tracing. So COVID response, personal protective equipment was key in COVID pandemic response. There's a lot of controversies. There's some controversies surrounding it. I'll go through it later. But of course, we want to make sure that direct contact, when in Singapore, from the word go, we used N95 masks for COVID response when we are dealing with suspect and confirmed cases. We were not aligned with other guidelines, but I think lately most guidelines also recommend N95 masks or equivalent for respiratory protection. We use full sleeve disposable gowns, gloves, and eye protection. PPE stockpiles are centrally administered at national level, and retraining for PPE were conducted at institution level. So this is so what happened during the pandemic was our ICNs were like, our ratio is 1 ICN to under 10 patients. And imagine when the whole hospital explodes with COVID patients, it's impossible for the infection control nurses to do the PPE training. So some of the staff in the hospitals took it upon them. Some of them were asked to do it. This is our HOD, Dr. Monica Chan, who since the start of the pandemic until now does PPE training for every medical officer who comes to our department, rotated to NCID. So these are the things that happened on its own, because which helped a lot for infection control. So new pathogens need new IPC research. This is the next part that I'm going to talk about. So IPC is a field that, as I mentioned just now, it evolved with lots of history, lots of tragedy as well, but mainly lots of history. But the research was lacking even before the pandemic, at least in our setting. The research was more like implementation research rather than identifying ground science for us to come up with theory and principles to apply IPC. So what happened when NCID was set up was, Executive Director Prof, who gave the talk before this, was every unit was asked to come up with pandemic response, and research was one of it. And infection control research for pandemic is something we set up like about 1 year before the COVID, and when the monkeypox landed, we did it, but we were struggling to do it. But we learned during the monkeypox when the SARS CoV2 hit us, we could implement the research quite fast. So transmission dynamics of a novel pathogen is the main thing that we'll need to research when a novel pathogen, when the pathogen hits us, because it will affect the PPE choice. It will affect the clean and contaminated area for segregation. Is it physical segregation only, or air segregation is required? These kind of decisions will depend on the pathogen's transmission dynamics. Implementation of mitigation measures, if your hospital or facility couldn't do it, will also depend on the transmission dynamics. So understanding this is crucial as a first research in a pandemic. Communication of risk to the hospital management staff, patients, everything will depend on the transmission dynamics of the pathogen. And coronavirus should behave like coronavirus is what many people said and we thought, but there's a lot to it than just a coronavirus, right? Because even within COVID-19, different variants behave differently. So we were glad that we had this opportunity to study the SARS-CoV-2 in detail, because we had different waves. Initially, we had imported cases from China, and we had this patient pool who were very helpful patients. We had the environment to study the virus, and then we had a lull period to analyze what we studied and publish them. And then we had the local search. So we could, by the time we had the local search, we knew enough to actually, implement IPC measures for this pathogen. So the study clearly showed extensive environmental contamination. So this is the study that we did in a typical NCID room. If you see, we have E wing and F wing. In the F wing, there's no anti room. E wing, there's an anti room. This study was done in the E wing with the anti room. So the yellow markers are the viral particles. We could only identify viral particles, and no one could do the cultures because everyone was very busy. So we just tested RNA in our DSO, Defense Science Office laboratory, and you can see the floor was extensively contaminated with viral particles, but all over the place there's environmental contamination. We found there was evidence for air contamination as well, but this was not found in the initial air samplers. We learned research while doing the pandemic research, because IPC, air contamination and mitigation, wasn't really IPC, or at least where I worked or working now, a priority, because we always had airborne infection isolation room and we just put TB, measles, everyone in there. So we didn't really need to delve too deep into it or question too much of it. But this pandemic actually changed the paradigm slightly. We also found, I said there was evidence for air contamination because we found the virus in the ventilation exhaust, which was a bit far from the patient, not too far, but a bit too far from the patient. So we were wondering, why did this go there, So we thought we are not at the end of the experiment yet. So this is the time we got involved, we got linked up with our aerobiologist, Kristen Coleman, and other aerobiologists from the world, and also Duke and US, which was, to me, was an enlightening moment in terms of how we should study the transmission dynamics of the pathogen. So we investigated the surface and air contamination further. In addition, the air contamination was investigated using NIOSH samplers, which could inform particle size. So this is what we found. What we found was that, sorry, I can't see. Okay, so I'll see there. So what we found was that when a patient is in a day 5 of illness, and the patient one of them was mildly symptomatic, we saw him coughing a little bit, but he wasn't really coughing. We actually could detect the viral particles in a particle size, which classical IPC calls airborne. So we could actually detect it less than 1 micron, the particle size was detected. So this showed us that the airborne transmission, per definition of classical IPC, is possible, but that's not the end of the whole story. And then in the same study and the same patient rooms, we investigated 17 patient rooms. We found extensive contamination of the high touch surfaces, which IPC classically focuses on in cleaning and decontamination. We also found the air vents contaminated. Additionally, we found that the environmental contamination actually closes down to 0 after around day 8. And this was the time when we also found that the dynamics of the virus actually is reverse of SARS 2003, where the week 2, the viral load actually goes down. So it sort of matched it. But even then, me too at that time, even then we were asking for viable virus evidence at that time. So I wasn't sure whether viable virus evidence was necessary for IPC or not. But some in this audience, as well as many from all over the world, were asking for viable virus evidence, whereas there was another group which was arguing that this is already enough evidence, and Twitter was exploding with it. And talking about airborne transmission was such a sensitive topic on social media. But this is what we found at that time. That's the research in IPC. If we didn't do the research, what I would have thought is we would have stuck in the middle of this discussion without knowing where we should move. So the point is that we should do our own research when there's the next pathogen comes, and we should be prepared for it. We also conducted research to allay fear, people who were so scared, and understandably so. So one of the key things was shoe cover. We gave gown, glove, eye protection, and N95 mask, but there was this need of shoe cover from the staff. But we know if you actually contaminate your hand while removing the shoe cover, that will contaminate your eye, nose, and all. You might get infection. So we did this study, and unfortunately, our first study actually showed one of my SR who did the sampling with me, his shoe front was positive for the virus, so everyone was freaking out. So when we repeated the same study in a more extensively, including 30 staff, cleaners, housekeeping staff, various time of exposure in the room, none of them showed contamination of the viral, none of them showed viral particle on their shoe front, mask, eye protection. We used this data to inform our hospital staff that, look, you don't really need shoe cover. But however, we needed to place a chlorine mat on the exit from the hospital because they started asking about the bottom of the shoe. So we thought that, staff psychology is a very important thing in a pandemic and not before the pandemic. So we placed the chlorine mat, which are still there. Initially, I saw people were stepping on the chlorine mat and rubbing their shoe on it before they leave. But nowadays, no one even bothers to check if there's a chlorine mat. That's how much we have evolved throughout the pandemic. So hopefully we can remove it soon because it's actually not so useful. So what were the points for IPC implementation that we found by doing research? Environment was extensively contaminated with SARS CoV2 and corresponded to days of illness. Environmental and hand hygiene are important measures to prevent transmission. Early illness may cause more environment-mediated transmission than late illness. We also found that SARS CoV2 was detected in particle sizes corresponding to airborne transmission for IPC. While viable SARS CoV2 was found by other researchers, we could not find any. So this brings me to the old dogma, challenged. So is it droplet? Is it airborne? Is it inhalable? Is it respirable? Is it formite? Is it touch? I mean, there were so many words. And so I'm in medicine for about 18, 19 years, and I've been in infectious diseases for about 11 years. My journey into infection control is still very, very short. I was just like 5 to 6 years in infection control. And I just accepted when people say airborne droplet, I just used it without questioning, which should not be the case when we actually do medicine or anything in our life. So when we started going deep into this, right, that's where I personally, this is my opinion, I don't think the old dogma was right, and we need to look deeper into it. Number one, 5 micron cutoff. This is completely out of the world after we actually read more. It is actually same yet not the same. It's aligned yet not aligned. So the aerobiologists have inhalable, respirable, and droplet are more than 100 micron, and the 5 micron differentiates inhalable, respirable. Whereas infection control stopped at 5 micron and separated it droplet and airborne, and that created all the confusion. They evolved, we stopped. So this should go out of the window as soon as possible. This is what I think. And no one, it won't change the world, but this is what I think. Number 2, what is needed? New classifications needed to guide IPC measures. IPC measures should be about what we need to do. It may not be aligned to what is the reality, but what we need to do on the ground. And it needs to be, and you need a different randomized control trial for IPC measures, even though the science says something. For example, we have found influenza virus in a viral RNA in a in inhalable particle, meaning airborne. But there's a study by Trish Pearl that showed outpatient N95 mask versus surgical mask in a randomized control trial. There's no difference in infection. So the science says something, but your randomized control trial may say something else because the implementation is slightly different. Next is we need to show viable virus for IPC measures. Personally, I think this is not necessary for infection control implementation. if you find a viral RNA, you need to protect your staff. I don't think we need to be waiting for viable virus before we implement IPC measures. So precautionary principle should apply, I think. If you feel that there is a possibility, you implement first, and then you do the research, you do the study, you come up with you understand the virus, and then you remove. Removing can be very difficult, but it can be done, right? But pandemic preparedness should also take resource availability into account. You can't say, I need N95 mask, I don't have N95 mask, so I'm not going to work. If you don't have N95 mask, you go to something that's less efficient than N95 mask, improvise it a little bit, and you still continue to work. But we need to know what we are putting our staff, what kind of risk we are putting our staff into. Is it acceptable, and what is the mitigation? Number three, droplet versus airborne for determination of IPC measures should not be used, I think, because this is not relevant anymore after this pandemic. IPC measures should be implemented based on the presence of viral particle. This is what I feel it should be done moving forward. If you have the viral particle, then you need to mitigate it. It's impossible for us to go around telling our staff, yes, I saw the viral particle, we detected the viral particle, but we haven't cultured it, so we're not going to protect you. So that communication, so this is the summary of how the old dogma was challenged and how I evolved during this pandemic. Just to be clarified, there's lots of things IPC did well that helped the pandemic a lot. This one thing is probably what we need to actually relook at. And when we had the COVID expanded in Novena campus and we needed to use one of our outbreak wards, we actually mitigated ventilation. This was last year. This was not even this year when this airborne transmission became very critical. But what we didn't do was, we didn't do it in all the wards. We just did it in the wards where COVID treatment is going to happen. Hence why there was a large outbreak in our hospital. We learned from it, we improved the ventilation after that. So COVID also created new frontiers in community infection control. We have never been tested in the community IPC like what we have been tested during this pandemic. So just to give you an idea of how it was before and where it all went, right? Transmission prevention in healthcare facility, transmission prevention in community living facilities like migrant worker dormitories, nursing homes, mental health facilities, prisons is where we needed to prevent the transmission as well. Control, entry, and prevention. These are ports. We needed to prevent transmission of ports as well, and other areas where workplace, etc., etc. We needed to prevent transmission in all these places. And we also have to have we needed information hygiene during this pandemic as well, because everyone with a keyboard and access to internet can give opinion and that may circulate. But as people who are behind the science, people who are implementing the science, our job to actually correct them if it's based on data. So pre-pandemic status in all this area, in the hospitals, they were quite good actually. They just have to adapt it a little bit. But in the communities, the communal living setting, the pre-pandemic status, there was no personnel, the competencies was non-existent, infrastructure was none. And the port of entry, okay, I must say in the port of entries in Singapore, there was a good safety culture. So we could tap on the safety culture and modify it to become infection control culture as well. Like for example, in Changi Airport, in road transport, etc., entry points, which was not easy, but easier than other areas where none of it was present. We do give communication to the press about, endoscope infection, carbapenem-resistant organisms. But during this pandemic, we all had to do extra work over time to actually give information to the press about XYZ. Is it airborne? Is it droplet? Is it transmitting this way or that way? Because if we don't do, no one else will. So we need to be more proficient in this moving forward. We need to use more social media. We need to engage public more so that when the next pandemic comes, we can be the voice of data and science rather than anyone else who would have been less familiar with data and science. So COVID-19 related facilities in the community were set up. This is the second last part of my talk at 5 more minutes. So the COVID-19 related community facilities was where the fight moved. Initially, it was in the National Center for Infectious Diseases and the public health institutions. After that, it moved squarely to the public. In the community, we needed to set up community facilities. We need to design the facilities, set them up, train lay people in infection control. This is where the IPC principle of training and education helped a lot. We needed to do surveillance, audit, and feedback. So we use the simple principle to set up the facilities. You need to provide right PPE. It's not a lot of PPE, but right PPE. It must be task specific, training, more is not better based on main modes of transmission. We focused on environmental hygiene, ventilation, and crowd control. And we focused on right actions, hand hygiene, physical distancing, protected use of personal items. And with this, we aim to protect the staff who were working in the community facilities, most of whom were not healthcare workers. So this is the principle we used to set up a few. These were the like the paragon of our isolation facilities. You know, the Changi Exhibition Center, which converted, and also the Expo, just converted. We also had many other isolation facilities. At the peak of the pandemic, we needed to convert some badminton hall and all into isolation facility as well. Thankfully, that didn't last long. So IPC and the next novel pathogen. I love this story, the story of the Smong people in the Simulu household. You know, when they say that whenever you see the sea is going backwards, you run up the hill. This was during the tsunami in 2003 to 2003, I think. None of the people in this island of the Sumatra died, whereas many other people, there was hundreds of thousands of mortality. That's because they learned from their past. We should too. Lots of learning points and for IPC practitioners in this pandemic to help us prepare for the next one. And the next one may come in the next 10 to 15 years. We need to be prepared. And what are the future pandemic for, and some lessons from me for IPC? So number one, enhance peacetime IPC strategies to facilitate pandemic IPC response. Peacetime IPC resource calculations should include business continuity plans during pandemic, because you still need to do CLAPSI audit while the pandemic is raging on, because your COVID patient may die from CLAPSI. So you still need to prevent CLAPSI during the pandemic. Pandemic IPC research is critical for pandemic response. Peacetime IPC research is critical for pandemic IPC research. So you need to do IPC research even during peacetime. And collaborative approach in IPC research, and keep an open mind to accept changes. I think these are the key points for IPC for future pandemic, I think. With that, I thank you and end my presentation.
Very much, Dr. Marimuthu. Okay, I got two questions for you. The first one, I'll just read the verbatim, is by Lin Lee. And it asks that if you found no virus on gowns after exit, why still insist on wearing a gown into an isolation room if you're not planning to touch anything? We sometimes put on a gown, step in a room, and then take it off again when we step out. Yeah.
But that's a very good question. You know, the thing is, the way how the we also found virus on the floor, by the way, right? We also found the virus on the surfaces. It depends on the ventilation. We thought about it, that it depends on the ventilation, how much staff interact with the patients as well. Now, it's rare to have transmission via gown and going out, like, or your own shirt if you're not wearing gown, right? But when it happens, it subsequently will get amplified. So the idea is to prevent even one transmission, right? So that's why we don't do it. When you can have it on your bedside, it can actually come to your shirt as well. We swapped in this area and this area, but the gown is so big, right? So you need to consider a few data and come up with the idea together. So yeah, so I don't think, we didn't find, but there were other surfaces that were positive. So that's why we should probably continue with the gown.
Excellent. Okay, another one by Julian Tang. And his question relates to inter-pandemic preparedness in Singapore, which is basically something that Western countries have failed at. And does Singapore provide ongoing funding for maintenance of PPE, diagnostic stockpiles between pandemics? Yeah. So I guess you had covered a little bit of that in your last couple of slides here. But do you want to answer this?
So that's not a question for me, right?
It was a question for you. Yes.
Oh.
Yeah, from Julian.
So inter-pandemic preparedness in terms of PPE stockpile and all, right? I think the procurement of PPE was done very well by whoever that's doing it centrally in the government. They did very well. And I don't think the PPE stockpile that we had pre-pandemic was enough for during the pandemic. It was just a lot more than what we expected, but they did very well to get the PPE that we require for the pandemic. I'm not qualified to talk about the inter-pandemic diagnostic test preparation and all, but that might be Sean who is going to come and talk next. He can talk about it if he touches on his topic. But I think the most important thing is scalability and flexibility. When you're trained to prepare for a pandemic and when you are tested, you can adapt, adopt, and come up with new ways. That's why we need to prepare and train on research before the pandemic, so that we can adopt during the pandemic. Yep.
All right. Thank you very much. Thanks for a great talk.
Thank you.